All right, we are live once again. How you doing, Ann?
I'm great. How are you?
I'm doing good. So who we
Good.
have joining us tonight, Ann?
Tonight we have Scott Watkins with Family Hospice. I'm really excited to have Scott on tonight to talk us through some myths and some truths about hospice.
Excellent. Looking forward to having Scott join us. So let's count this down
Okay.
and let's get this going.
All right. Sounds good.
Scott, welcome to the show.
Thank you for having me very much.
How you doing today?
I'm well. I tell people all the time I can't complain and would not do any good if I did.
It doesn't help, does it?
No, not at all.
Well, let's kick this off, Scott, and just tell us a little bit about yourself, background, anything you like to share.
Sure. So keeping it relevant to hospice, I began my hospice career in 2010. Started in hospice as a chaplain and a bereavement coordinator.
Wow.
And so I'm a clinically trained chaplain, have a master's of divinity. And then as my time in hospice began to move forward and roles evolved, as it often does in various career paths, but I got involved in the care coordination side of things. And so these days, I'm the area market manager in Middle Georgia for Family Hospice.
So what led you from chaplain to this?
Opportunity. I've told people that I have practiced and worked in hospice all over Middle Georgia. I live in Milledgeville all my life. And, but my first role in hospice as a chaplain was based in Dublin, which is a pretty solid hour from Milledgeville. And so I've been based in Dublin. I've been based in Wrightsville. When the opportunity arose for me to be based in Milledgeville, about 5 minutes from my home, it was not in a chaplaincy capacity. It was more the marketing side and care coordination side of things. And so I kind of seized the moment to be close to home. And it just so happened I found my real passion in hospice. Chaplaincy has a way of still integrating its way into the work I do every day. And just a really solid foundation that I formed in hospice, working in chaplaincy, just being at the bedside. I'm not at the bedside so much anymore these days, but I do have that experience as part of my foundation and how I got started. And so that very much informs how I move and work in hospice today.
Well, you'd be familiar as well with end-of-life doulas, because Kim Poor, she has joined CareQuest, and that's what Kim has done is end-of-life doulas. So obviously that's all kind of close hand in hand. I'm sure you experienced a lot of that as well.
Yes.
But we're going to go through and ask you some questions, and let's see if we can't help some people out.
Sounds great. Fire away.
All right. Well, we're glad to have you. I'm so glad you were able to join us. I really appreciate you doing this for us and helping us get this information out. So let's just start out with the basics, really. And if you would explain to everybody kind of what hospice really is.
Wow, that's a big question with a lot of different paths that we can go. I'll keep it as foundational as possible. So hospice is a Medicare benefit for which someone has invested into all of their lives. And so a lot of people wonder how hospice is paid for. And the answer is 100% through Medicare Part A. A lot of people will say, okay, well, I have Humana, sort of a managed Medicare, or I've got UHC. Doesn't matter. When someone elects hospice care, it reverts to the traditional Medicare, and it's covered under Medicare Part A. If someone doesn't have Medicare, but they have Medicaid, it's fully covered under Medicaid. If someone doesn't have either one of those things, it's usually covered fully under someone's commercial insurance. And in a lot of cases, hospices, including family hospice, will take care of people free of charge on an indigent basis as the needs do arise, and we're able to evaluate them for appropriateness. So that's positions hospice as a Medicare benefit. But what hospice truly is care for someone's final season of life. I prefer to say it that way instead of end of life care, because when people hear end of life care, it's scary, and but the last time I checked, the mortality rate is 100%. And, but that being said, we all have an appointed time, and hospice is not about ushering someone's final day and making that happen quicker. Hospice is about taking someone's days one day at a time and making sure that those days are full of peace, comfort, and quality of life. That is delivered, and how that goal is achieved is through what's called an interdisciplinary care team of hospice professionals, from nurses to CNAs to chaplains to medical social workers to volunteers, all working together to provide comfort and quality of life for patients and for their families. It's not just for a patient. Outside of the personnel, hospice also fully covers medical equipment that might need to be placed in the home, not uncommon for people who need a hospital bed or a bedside table or a walker or a wheelchair or a shower chair or something like that. Even things like a Hoyer lift. Hospice will provide those things. And it's not like other services where, if you've ever utilized home health and you need to get a hospital bed, you have to go to the primary care to get the order, and it can be a bit of a tedious process. In hospice, it is very simple. If we're notified, say someone's discharging from a hospital and they need a hospital bed, and we know about that at 9 a.m., we'll have that bed delivered and set up in that person's home, wherever they call home, within hours. And so it's
I think it's kind of, to throw in there as you were talking, we're explaining what hospice is. And I think a little quick thing of what hospice is not is just like when we had mom come home with hospice is not going to provide someone there 6, 7, 8 hours a day.
That's right.
It doesn't work that way. They do provide the equipment, but the nurses come by on a visited basis. And how often is that? Is it always once a week, or is it depending on the case?
No, so everything that we do in hospice is individualized care. To wrap up, though, what the benefit fully involves, I mentioned the equipment, but also medication coverage as well, as well as supplies, oftentimes incontinence supplies, things like that. But to your question, Mark, everything is individualized care in hospice. And so a nurse may visit 1 to 2 times a week. Maybe let's just say there's an exacerbation of a symptom and it needs managing. That nurse visit frequency might increase to 3 or 4 times a week until that symptom's under control. And then the frequency may reduce back down to 1 or 2 times a week. Everything can fluctuate all the time based on the individual's needs. Of course, when we identify through certain criteria that someone's beginning to transition into their final, days or week of life, the visits then become every day. And of course, the main benefit with a hospice nurse is that we are on call 24/7, 365 days a year. I tell people all the time, I don't care if it's 3 a.m. on Christmas morning. If you need a nurse, you call us and we will be there. Someone put me to the test last Christmas. They called me. They called me at 6 o'clock on Christmas Eve and said, "My dad's discharging. I think we might need hospice. Can we get oxygen?" And I said, "Of course."
No. Yeah. That's the part that really hits home when you get to help them in those real times of need like that, and really show them what it's all about. So I know you're talking about you did the supplies. So you're talking about, when you talk about supplies, you're talking about if it's wound care, if they have briefs that they need, you guys supply all that and bring all that to the house.
That's right. We supply those things, do colostomy care, catheter care, the whole 9 yards.
Yeah. And I just think that's so important for people to know, especially for hospice at home, because so many times they are worried about how they're going to get that stuff. And, I got to run to the store and I got to get this and I got to get that. And they don't have to do any of that. You really take that off of them by supplying those things for them. So that takes a lot of stress off of a family a lot of times.
It does.
Well, who qualifies for hospice, and is it is it only for the financial, well-off people? Like, what's the diagnosis?
No, again, if you have Medicare, Medicaid, most commercial insurances, from if you're concerned about how will this be paid for, that is often the very least concern in hospice. It is really the simplest thing that, in hospice.
And that can't be stated enough, really, because
it can't be. And people don't realize that, just how available this benefit is to them, how it truly doesn't cost anything. But in terms of qualifying not from a financial, but from a medical perspective for the care, a physician has to certify by signing what's called a certificate of terminal illness that this person may have 6 months or less to live based on their diagnosis and or prognosis. Now, sometimes people hear that and it scares them. You're telling me I'm going to die in 6 months?
Yeah.
Well, no, but as you know, Medicare, CMS, they're very particular about how some things are worded. And so that's the wording that they're comfortable with,
Yeah.
And it is true. If I had a hospice medical director explain it to me a different way years ago, and it's always stuck with me, that yes, we do have to sign an order and a certificate of terminal illness certifying that this person may have 6 months or less to live if the disease follows a rather predictable course. He said, but what I wish you could say was, if this person doesn't have an intervention, then it is likely that they're not going to live beyond 6 months from now. So what in reality happens is, although hospice is not curative in nature, it's palliative care. So it's managing symptoms and managing pain at home so people can stay home and stay out of hospitals. But what it is that we come in, and the care that we provide, albeit not aggressive, does just what I said before. It increases peace, it increases comfort and quality of life. And so that intervention from hospice often is what extends people beyond 6 months, and they still can receive the care beyond 6 months if they're eligible. But had it not been for hospice, they likely would have passed away in 6 months or less. It's been a while since I've looked at the stats, but the last time I did, it was shown that just nationwide, people who have hospice live an average of about 30 days longer than those who don't. And so, you think about a loved one you've lost. I think about loved ones I've lost. I'd give anything for one more day. Hospice is often the gift of not just one more day, but maybe even 30 days.
Well, and just to be completely candid and honest, with this conversation, I agree with that, but it depends on what your loved one's going through. Like my mom's suffering so much, we're praying for God to take her home. So there's a fine line between wanting to, agreeing what you're saying. I'd want to have as much time with my mom as possible, but at the stage that she is at, it's like, I'm just ready.
Right.
Everybody's ready for her to go home. We had a question for you. Do you want to say something, Ann?
No. Well, yeah, I do, because I understand where you're coming from. I've said a lot of times, to a lot of people that, I lost my mom when she was 90 years old. I would have kept her another 90, but not in that wheelchair, not like she was.
Right.
However, I will say, and I dealt with this even today, when we talk about people and their wishes And I think, Scott, you're right. I think you're both right as far as talking about that, because it happens, and it just is by case with everybody, of course. But I would dare say the majority of people out there, you're right, just one more day or 30 more days, because I see too many people over the years that want to have everything done. So when you try to discuss with them signing a DNR, they're not going to do it.
Yeah.
We want everything done. And so I think a lot of people do think in those terms, and it's just because it's scary, and it is. And I know hospice really speaks to a lot of that with families, because you've got such support.
That's right.
For the family.
We had a question further down the line. So I bumped it up because you mentioned the word. So here's the next question.
Yeah, I know. We're just going to run all over these questions. It's okay. But yeah, we did want to talk about the difference in hospice care and palliative care, because I think people get confused with that.
Mm-hmm.
Yeah. And if I'm being candid myself, it's a confusion that I think hospice, just generally speaking, has created. Palliative is often a more palatable term to people. Hospice, I used to tell people, and I still do sometimes, just joking, hospice might as well be a 4-letter word. Nobody wants to say it. Everybody's scared of it. Palliative's not so threatening. And often people think of palliative care and hospice care of being the exact same thing, just with different names. And there is a shred of truth in that, but palliative, hospice follows a palliative philosophy, meaning that the palliative philosophy is not to cure, but to treat, to treat symptoms and to treat pain without curing those things, because modern medicine has already determined, that a cure can't be reached. Right. And so all hospice is palliative in nature, but not all palliative care is hospice care.
Hospice care.
Right.
Okay.
And so hospice is like we said, a Medicare A benefit that provides all the things that we mentioned. Whereas palliative care is billed under Medicare Part B. It is there for someone, let's just take, for example, that has a cancer diagnosis, and they are still pursuing aggressive curative treatment like chemotherapy. Hospice would not be appropriate for that person, because Medicare says, if we're going to do aggressive curative treatment, that is certainly your wish and your right, and you can do that if that's what you want to do. But if we're going to do hospice, we can't do both of those things at the same time, right? So palliative care is for the person who's seeking aggressive curative treatment, but maybe needs some occasional help with symptom management and pain control at home. Oftentimes those things come along with various cancer treatments like chemotherapy and radiation. Generally speaking, and I'm painting with a very broad brush here, but what palliative care is a visit from a nurse practitioner in your home about once a week, or excuse me, not once a week, about once a month. And so maybe it might be a couple of times a month. It may be in person, it may be telehealth, that kind of thing. There will be a copay, that's different for every person. It's not a fully covered benefit like hospice is. And all those other services that I mentioned with hospice, from the personnel to the tangible things like the supplies and the meds and the equipment, those things don't come along with palliative.
No.
Okay.
And I think where I see palliative care, I'm sorry, Mark, more often people request or talk about palliative care more often is in a nursing home setting, when there's a patient that maybe they've gone to the hospital, they've come back with a new diagnosis, and a lot of the doctors want to talk about, well, let's just do palliative and talk with the family about doing palliative care rather than doing hospice for those people. And again, depending on what they choose to have done and what they're going to do. But, of course, that's my wheelhouse is nursing home. So that's where I hear, a lot of that has been around the nursing home, and some of the docs there, wanting to look at maybe instead of having to do hospice care with the person, do we want to do palliative care? Does the person want to do palliative care? And I think that it gets interchanged more than it should sometimes.
And a lot of times, even when physicians or nurse practitioners are speaking with me and they mention wanting palliative care, I will ask the clarifying question, are we talking palliative care, like true palliative care, or are we talking about hospice? Because there's a big difference.
Yeah. Yeah.
Well, Ann, I'm shuffling the deck as this conversation goes. So that's why I popped these up. So this conversation has made me move this question up a few notches because we've touched on it. So how does hospice work in a nursing home or assisted living setting? And is payment different in those settings?
Well, that's a deep question too, with a lot of answers. Okay, so that let me just say it the simplest way is that hospice care is provided wherever the patient calls home. That can be in their personal home that they've lived in for many years. That can be in a nursing home, an assisted living, a personal care home, in a hotel room. If that's where they're, hospice care is provided wherever you call home. When it's provided in an assisted living setting, it's pretty much just like being in someone's personal home, except for there are staff members on that assisted living who are also overseeing and providing care. And so they don't necessarily withdraw what they do because hospice comes in. Rather, we team up and become all hands on deck approach for the patient and family. And it is also that same approach in a nursing home. We team up, we become an all hands on deck approach. Hospice does not necessarily cost more or less based on where someone is residing. If you really want to get deep in the weeds of like room and board, that can get a little complicated. The bottom line is that if you reside in a nursing home and your room and board is being covered by a benefit, the addition of hospice care is not going to conflict with that.
Yeah. Yeah.
So payment basically stays the same.
That's right.
And the thing when you're mentioning that there's staff in an assisted living and there's staff in a nursing home, and the big thing with that is when you're at home, your family is dispensing your meds. If there are things, and I'm going to bring this up, and I may be stepping all over another question we were going to discuss too. I don't know, Mark. Sorry if I am. But I do want families to know that, they may be at home and yes, they may be dispensing their meds. Where in a nursing home or assisted living, the staff is still going to be giving the medications. And sometimes that scares families about having to give meds. But you guys supply the support.
That's right.
And if there's any kind of, I don't know I'm not even trying to think what it would be off the top of my head, but if there's any type of treatment or anything at home that they need to know how to perform, because you're not there 24/7. You guys are going to train them. They're not going to be left on their own, and you provide that support to them. You can even provide that type support. That would probably come more so like in an assisted living, maybe med techs, that kind of thing. It may be where you teach staff or something like that. Is that not correct?
That's right. We are always training caregivers in any setting. So if those caregivers are family members who will administer medications or med techs in a facility, we're training so that, everybody's on the same page and in agreement and has an understanding of what to do and when to do it, And again, with the reassurance that we're 24/7. So if you ever have a question, call.
Right. Yeah. And I know that you're 24/7 because I've worked with a lot of hospice nurses. And I've also had to have our facility call hospice in the middle of the night. So you are, I know that you're there and you're really there for the families. And I did kind of dip down because really we wanted to talk about a little bit about the family's role, and that really kind of defines their role in this. You guys are there to
Let me
support
bump
them.
this up.
Yeah.
So the next question Ann has then is,
talk a little bit, if you can, because I really want to put people at ease about hospice. I just think you guys do such a phenomenal job with what you do for families. So talk a little bit about what the family's role ends up being.
This is
with
good.
a loved
Yeah.
one on hospice.
Yeah.
Well, what we want most for our families is to feel peace and comfort and assurance that they have the support they need. Oftentimes when we become involved, people are burned out, worn out, exhausted. They have just been on this hamster wheel, of healthcare and in and out of hospitals and treatment centers and half a dozen doctor's offices, and transportation becomes, getting their loved one to those appointments becomes very difficult, and they're just burned out. And sadly, they think on some level, not all the time, again, nothing's cookie cutter, but I encounter it a lot that, my gosh, I just don't want to feel like I've given up.
Right.
And hospice is not that. Hospice is a shift in perspective of what it's going to mean to live out that final season of life. So most of all, what we want them to feel supported, and that they've got backup, and that they've got a team of caring professionals who are going to help walk them through each and every day and hold their hand and make sure that, hey, everything's going to be okay. There may yet be rough days ahead, but we've got you.
Because you supply, just like yourself, starting as a chaplain with hospice, you supply a whole team.
That's right.
Of support.
That's right. Now so when I think of what is their role, I would love for their role to be able to sit back and take a deep breath and know that they have support. Day to day, they're going to be what we call, primary caregivers for their family member, assuming that that's sort of the role that they take on. They will be the one who is present there all the time with their family member rather than us. We are very present and very involved, but as you mentioned, we're not regulated to be there all the time.
Right.
We have to follow those guidelines and those regs, what their role is simply to be able to be present and to be a caregiver who is maybe no longer exhausted.
Well, and speaking of that, and I can't believe I didn't even think about us to talk about this piece, but I think it's very important for families to know that you guys provide respite care.
We do.
And that you can get them placed so that family member does get a break, for a week or so. And, even if you start at home on hospice, you can still transition very easily, if needed, into a skilled facility or nursing home setting and keep hospice to go along with you.
That's
so
right.
that can happen to give the family some relief.
That's right. And that kind of gets into the 4 different levels of hospice care, which really is getting real deep in the weeds. Respite care, I would say, is, the second most utilized part of hospice, the second most utilized level. We are able to give families that respite break. We partner with different facilities, so if someone has a loved one in another state who has passed away and they need to attend the funeral, but, the patient can't go with them, then we can set up a respite care. Transportation, is involved to get the patient from home to the facility and then back home. While they are in respite care at a facility, a member of the hospice IDG team checks on them every single day. And so, we're very connected and very involved, but not just for situations like, a death. That's just an example, one of many, like you said, if they need a break, if they need a vacation, if they need to go look at a beach or a mountain, they can do that. And, if
may not come back.
Well, there are often times that patients tell us, man, we were supposed to have a beach trip next month, and I really want to go, but I'm on hospice. I guess I can't go now because I'm on hospice.
Oh,
Actually, you can if you feel like it. With hospice, you do not have to be homebound. If you feel like going to church, go to church. If you feel like going to your grandson's ball game, go. If you feel like going to the beach, go. With something like home health, which I know y'all talked about in the past, that you do have to be homebound to receive that. So the hospice is not that.
Okay.
Well, what it's kind of been touched on, but what would be the main myths that you would say are the biggest things surrounding hospice care?
Oh my goodness. Well, one is if I have hospice, that means I can't go see my regular doctor, my primary care physician.
Yeah.
That is a myth. You absolutely can go see your primary care physician. And in fact, if your primary care physician wishes, he or she can oversee and be what we call the attending physician for your hospice care. Now, oftentimes primary cares don't want to take on that responsibility. And it's not because they don't care for their patient or that they desire to be disconnected. It's simply because they are not an expert in hospice care, as our medical director would be. Every hospice has its own physician, medical director, I tell people all the time, if you still want to go see your primary care, go, we all need to know and be on the same page that you're utilizing hospice, And so, no, you can absolutely still go see your primary care physician. I don't know, what other myths have y'all heard?
Well, I think we were talking before the show even a little bit about, I know you say it in a different way, but, whether it's end of life or that 6 months and that it's just a given and for people to understand maybe that, through hospice, they can sometimes, and I've seen it a lot over the years in a nursing home setting, and a patient might get better. That doesn't mean they have to come off of hospice at that point necessarily, but I think a lot of people think it's a death sentence if you talk to me about that hospice word,
Yeah. And a lot of people sadly refuse a hospice consult simply because they hear the word and they stop right there. I don't want to talk about hospice, and that's okay. We live in a free country. People can decide whether or not they want to talk about hospice. What my wish is to always educate people as to what hospice is. And that way they can make a fully informed decision, whether it's yes or no. Educate, get all the education, get all the resources, and then make a decision. No, if you're going to say no, know
what you're saying no to. Yeah.
Know why you're saying no. Yeah.
That's right. And that's okay. But a lot of people do perceive hospice as a death sentence, and it's a perception that is well earned. When hospice care first started rising to prominence in this country, and started the late 70s, early 80s, as I understand it, it was largely a volunteer-based program. It was not yet part of the Medicare benefit, and it was done by just good-hearted physicians and nurses who wanted to take care of people. And so, because it was structured in that way, when someone needed hospice care, they really were at the final few days, 2 weeks of life. They really were. And that perception was the foundation of hospice care in America. And that's what everybody at the very beginning understood it to be. I remember sitting in church pews as a little boy at 8 years old, and our pastor would say, pray for Sister Smith. They called in hospice. You know what that means.
Right.
And so a lot of people still think that way today.
Absolutely.
Yeah, hospice has evolved, as you mentioned, and has become a Medicare benefit. And back then, it was really mostly for people who had a diagnosis of cancer. Nowadays, hospice, my goodness, a diagnosis that you could be admitted to hospice with is just a number of things, really from head to toe. Of course, there's cancer, but nationwide, cancer is in the minority of hospice diagnoses these days. A lot of could be neurological, whether it be Alzheimer's, Parkinson's, could be heart, could be lung, your COPDs, emphysemas.
And there's a lot of that.
Heart failure, heart disease. Certainly as obesity rises in America, we see more of that. So hospice isn't just for cancer these days, but I say all that about the diagnoses to say that when someone accesses hospice care and they're a non-cancer diagnosis,
yes,
those are the people, and they are the majority of people on hospice who generally live way, way longer than, days and weeks.
Yeah.
These are your people who live months. Yeah. These are your people who live beyond 6 months. These are the people who even sometimes can live years on hospice. And so, you don't have to, circling back to when we started, to say that, a physician says with a CTI, certificate of terminal illness, that, you have to have a diagnosis of 6 months or less, or a prognosis. That is true, but oftentimes people get to that 6 months, and wouldn't you know it, God hasn't called them home yet, and so that person oftentimes is still going to be appropriate for the care.
Right.
I'm going to drop a bomb here.
Okay.
I can't help. I can't help but be just raw, real. And when something comes to be, and I'm thinking about the experiences my family has, and to go along with what you both have said, that was my view of hospice before I got into this profession, on this side of it. You kind of get educated. That's part of the show is wanting to educate people so they understand the resources that are available out there and what the true meaning of each thing is that they have to face, including hospice, palliative care, Medicare, Medicaid, VA benefits, on and on it goes. With you being a chaplain as well, and I probably have shared this with Ann in private conversations. For those of us that believe and have faith, there's that thing called free will, right? And free will can intervene and get in the way of a lot of things here on earth. What I've noticed, and hospice can allow people to live another chapter of their life. Like we've said, it doesn't mean that they necessarily going to mean end of life. But I think sometimes that we get in the way of free will and this intervention medically. People live longer than they would be living. In other words, they go through a few months of unnecessary suffering because of the medical intervention. That sometimes it's time to pass. So I'm watching that with my own mother. And I'm just being as raw as it can be. And I want people to peel back and be honest, to go. I know that people face these things. No one wants to lose a loved one, but no one wants to see a loved one suffer tremendously. And I'm watching my mother, who should not have survived the hospital. We were told she would not survive the hospital. But when you're pumping them full of steroids, you're pumping them full of antibiotics, you're pumping them through, Lord knows what they're being pumped full of. They're having oxygen forced into their lungs. That they make it. They don't die when they would have died. And now she's home with hospice, and I've said bye to my mother 4 times already. And she just will rally. And I'm watching medical intervention. And my sister will say, well, God takes us when he wants to take us. And I'm like, well, there's free will. We do get in the way. So I just wanted to, for what it's worth, throw this out there, because I know you had to face these things as a chaplain.
Well, I know you. Yeah. I don't mean to interrupt you. Please continue.
No, I got it.
Yeah. No, I agree with you, Mark. I mean, for all I know, and I'll use the language of, my religion, God might call me home when I'm 77, or
Yeah.
I can go stand out in front of a train tonight.
Yeah.
Right?
Yeah.
Like
Mhm.
we have choices. I've often said, and in my experience in hospice as a chaplain, I think people sometimes are, in more control of their last breath than we think.
I agree with
Yeah.
that.
Now, I will say too, this goes back to what you said earlier, and I often say it really comes down to when you're making the decision, is hospice right for me?
Mm.
It comes down to a phrase that we
Yeah.
often use of quantity versus quality.
Quality.
Yes.
Yeah.
Yeah. Now, you may, if you continue on a path that you described just a minute ago, you might get more days, but will they be good days?
Quality. Yeah.
Right.
Yeah.
Yeah.
If you choose not to go the path that you described, you might get fewer days, or you might not. We don't
Yeah.
know.
Yeah.
We
Yeah.
don't know. But what's for certain is that those days, while they may or may not be fewer, they will most likely be more peaceful. People
Yeah.
want to be in their home.
And I want to just chime in with that piece too. Because Mark, I know you and I have, and you've said some stuff to me about those things. And one of the things I know with hospice, and I think this goes maybe back to some of the myths, even Scott,
Mhm.
because I've had a lot of families over the years say to me that it was, they're giving her morphine,
Mhm.
and they've got mama so doped up and blah blah blah.
Mhm.
Okay,
Well, that's a big myth.
morphine is not, yeah. Well, they're giving her that and they're just going to kill her, giving it to her. No, 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 no. That's not what's going on.
It's not what's
It is helping their body to relax so that they are not laboring.
That's right.
It is taking care of some of the pain and taking away, some of that. Um, but, I think both of you are, I mean, we're all saying the same thing, really. I mean, we do have free will. We do. But I'm going to tell you what, I always go back to my mama stories because we have great stories. But my mama said to me one time when she was in the nursing home, she said, I just don't know why God still has me here.
Yeah.
I don't know why I'm still here. To which I replied, as the only girl and trying to be a good daughter, I said, well, mama, that's just really not our call. And she grabbed my hand and looked at me and said, well, young lady, I think I'm who taught you that. So I said, well, yes, ma'am, you were. So no more questions. Because that's not our call and it's not in our hands. And so
Right.
we do the best we can do for our loved one. And we do what we think is the right thing at that time.
That's right.
And, having hospice on board, I think brings a lot of peace. I think it brings a lot of peace for families. And I'm a hospice fan in that respect. I do think that you guys do a great job for families and that kind of thing. So I really appreciate you being on tonight and sharing with us. Mark, were there any other questions or things you wanted to bring out?
No, I just appreciate it coming on the show. And I think that's it's important to me is being just authentic.
That's right.
It's because we all know you both have been in this industry far longer than I have. And the thing I'm thankful that I've been involved in this industry as I'm facing these things with my mom and dad. Doesn't make it easier emotionally. I'm not able to handle it emotionally like I can help other family members that comes across the path. But just want people to know it's okay to not be okay.
Yes.
This is a lot to deal with. And you're having to undo years of misinformation. Like you said, Scott, being a kid in hospice, get the shovels out.
That's right.
So but then fast forward and you start learning and seeing the true essence of what it is. And I'll just say, unfortunately, why do you think there's so many hospice companies out there? It's because it's a massive need. One company couldn't keep up with all of it.
Yeah.
But I just want people to know, and Ann and I both want families to know, the reason we're doing these shows is to get content out there so someone can stumble across this channel and hear something that helps their life out, that helps them breathe a sigh of relief and go, I'm so thankful that I heard that.
Yeah.
I'm so thankful that I was directed in that direction. And so that's what I, want to leave. And that's like, as we were talking, like you even said, Ann, you can't help but think about your own mama's story.
Yeah.
You can't think about your own circumstances and situations. I'm on a flag lot. I can throw a rock at my mom and dad's house. So I feel the presence of them right behind me as we talk. And I know that she's out there suffering.
Well, I'm going to say this to you, and I know that we have to wrap all this up. I could talk about this stuff for hours.
Mm-hmm.
But I will say, Mark, and I have said this to families a lot of times, you made the comment that your mom will rally, and that kind of thing. And I know it's hard to watch because I told you that on the first podcast we did together.
Mm-hmm.
Just because I was a nursing home administrator and around all these years, it did not make it easier with my mama. It was my mama. Yep. And it's very different. It is. It's very different when that's our parent. But when your mom has those moments where she rallies, I don't know, Scott, what you guys say to them, but I tell families all the time, you hold on to those rallies because those are blessings. And one day, I promise, you don't think so right now, but you are going to look back and be thankful for those little times that she rallied. Because when they're gone, they're gone. And it's a very different world. I don't have either one of my parents. Right. And it's a very different world without your parents.
It is. I don't have my father, and we didn't get the experience of hospice with him. He passed suddenly of a heart attack. And so, but loss is tough, and that's one of the that's one of the things. One of the benefits about hospice that people don't realize is that we're not just here for the life; we're also here in the death. And so we provide bereavement support for 13 months after.
Oh, wow.
After a loved one passes away. Yeah.
Well, Scott, we really both appreciate you coming on and sharing all your experience and the things that you shared. So obviously this is a way to get a hold of Scott, how to get a hold of Ann and myself. So we want to thank everybody for watching the show. We encourage everyone to like, subscribe, share, comment. All those things help. And if anyone needs help placing their loved one into assisted living or memory care, that is what we're here for. Thanks to everybody. Appreciate your time again, Scott and Ann. And we will see everybody on the next show.
All right.
Thank you, guys.
Thanks.
Bye-bye.